Thank you so much, everyone, for your patience. So let's begin today's session. Good evening and a warm welcome to all the dignitaries present here. I'm Shreyushi from Clanet, serving as the allocated session assistant to ensure a seamless experience. Clanet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for the doctors. It is with great pride that Clanet serves as the digital partner for this event, hosted by the Indian College of Anesthesiologists, and the focus of today's session is ICA virtual classroom case discussion. So let's begin today's session, for which I would like to invite Dr. Muralidhar Kanchi sir to take over. Over to you, sir. Please proceed with the talk.
Welcome to this ICA webinar, which is a academic activity under the auspices of Indian College of Anesthesiologists. It is almost a hallmark of the ICA, that is the Indian College of Anesthesiologists, which is being conducted every Wednesday between 7 to 9. Very successful program with a lot of quality talks and discussions going on in this webinar. Thank you for joining us. And today we have a very important topic on sepsis and what we should know about it so that our patients do not succumb to this terrible illness. So before we do that, I would request Dr. Belani, Dr. Jayashri Sood, and if Dr. Radhakrishnan, Dr. Baljit Singh, to say a few words about Dr. Ronald D. Miller, whom we lost on the 27th of February. He is known to every anesthesiologist on this planet. His contributions are phenomenal, and it is with a great sadness that we would pay respect and homage to that personality. So, it, to begin with, I would request Dr. Jayashri Sood, the president of ICA, to remember him. I think he will remain with us for a long time to come. Jayashri Sood.
Good evening, everybody. Indeed, it was we heard the sad news this morning, and it was very, very shocking and very sad. And Ronald Miller, and in fact, he had come to India a couple of. He was such a humble personality, and we all know him. Besides that, all the students know him as Miller, the textbook of Miller, and it's a truly a great loss to our anesthesia fraternity. And but great people always leave us so that we can continue remembering them. They are left vision of his in the form of the textbook of Miller. With so many editions and the volumes will stay with us and the students forever. May his soul rest in peace, and may his family members be given, God give them strength to bear this irreparable loss. Thank you.
Thank you, Dr. Jayashree, for that speech. Dr. Baljit Singh, would you like to say something about Dr. Miller?
Thank you, Dr. Morley, for the opportunity to say a few words. Well, truly a great man we have lost, and I think it's not only loss to the NSCF fraternity, it is a big loss to the world at large. His contribution in the form of the book that students read, and this is considered the last word in anesthesia. So whatever is written there, that's taken as a gospel truth. I mean, it's such a phenomenal collection of literature, no, not just literature, scientific literature, I must say that he has compiled, and this will remain with everyone. I remember the first time that he came to India, we had invited him for the Delhi annual conference many years back. And I still remember his gifting me a book of his own book, autographed, and which I keep it as a treasure with me. And that will keep me reminding of his presence. I remember subsequently he had come to Indore annual conference of ISA, and he remembered my name. I was so surprised. Such a great man, and he meets so many people all over the world, and he remembered one lesser mortal like me. I mean, I was quite impressed. Very down to earth, pleasant person to talk to. Well, he'll be missed by everyone. May his soul rest in eternal peace. Thank you, Dr. Kanchi.
Thank you, Dr. Baljit, for that message. Now I request Dr. Kumar Bilani, our counterpart in the United States of America. He is the international dean for Indian College of Anesthesiologists and actively involved in academic activities of both ASA and Indian College of Anesthesiologists. Great supporter of ICA. Request Kumar Belani to say a few.
Good morning, Dr. Kumar here. Can you see my slide there on the screen?
Yes, yes.
Okay, you can see the tremendous snow, and that's what happened last night. And the reason I put this up is because of Dr. Ronald Miller. He was born in Indiana, but the reason he moved to California is because he didn't like snow. So I just put this up to remind everybody why he actually moved there. And he served as the chief of the department from 84 to to 2008. And coincidentally, that's the time when I did my first research postdoctoral scholar work at UCSF with Dr. Sessler, and I met Ron Miller that time. So I had the opportunity to work with him closely as one of his faculty members and as a postdoctoral scholar. And after finishing my research in humans, they have a wonderful human laboratory there. All the experiments that they did on figuring out MAC, etc., for anesthetics were done at that human laboratory at UCSF. And after I finished my postdoctoral scholar work over there, he invited me to stay on as a clinical professor, which I did, and he supported my application, and I remained on the faculty there, even though I was a full-time faculty at the University of Minnesota. And periodically, I would visit there and meet with him. It was nice to see him come during our coffee breaks in the operating room and chat about current affairs. And he had almost anything under the sun that you could ask him, he would talk to you. He had a lot of work done as in the Navy during the Vietnam War and was stationed at Da Nang, Vietnam, where he did his work on massive blood transfusion and coagulation. And then being a pharmacologist, he continued to work on neuromuscular blockers, mostly the pancuronium, vecuronium, and rocuronium. And of course, his masterpiece was the textbook in anesthesiology. Started with one volume and then grew to many, many more volumes, and it was a thorough textbook. So I'm happy that I had the chance to work with him. I also traveled with him to a meeting in Tokyo, Japan, and had the opportunity to meet him there with his wife, and Kiran was with me. So I really, enjoyed his company, and he also participated with me in a study which we did in humans, which was evaluating the vasotract for non-invasive continuous blood pressure monitoring. And I do have a big paper with him in anesthesiology, where he was one of my authors with him. So I certainly missed him when he retired, but I did keep in touch with him intermittently at the ASA meetings, and have been disheartened to hear about his passing. I send his family sincerest condolences, and there is a chair set up in his name, and if people are interested, they can make contributions to the UCSF Foundation in his name to support further education and research. So thanks for giving me this opportunity to remember him and all the good times I had with Ron Miller.
Thank you. Thank you, Dr. Bilani, for that message, and we really appreciate the great contributions he has done.
Ice pack.
I request all these speakers who are not speaking into the meeting to keep their mics off. Kindly keep the mics off if you're not speaking into the meeting. This phenomenal personality is not physically present with us, but I think he will continue to stay with us and guide us in our daily practice of anesthesia, and also his wisdom is communicated to us through his unseen presence. Thank you very much for that. With that, I will move on to the scientific session of today's program. Today, the scientific session is titled Sepsis and Septic Shock. What anesthesiologists should know. It's a very, very important topic because we know that sepsis and septic shock have a high mortality of about 50 to 60%. And as the population in this planet is aging, and we have more immunocompromised patients in terms of diabetes mellitus or use of steroids and other anti-cancer drugs, this problem of sepsis is going to rise. And the other important point is that we already have the problem of multi-drug resistant superbugs. We need to have a solution for that. and that's why this topic has been chosen, and we need to look into the details of the pathogenesis, how do you diagnose it, how do you treat it, and what are the ways to see that the patient is out of trouble at the end of the treatment program, which we are going to look into in this today's session. With that short brief of the subject for today, I would like to introduce my panelists, co-panelists. Dr. Ratan Gupta, would you like to say hello to my...
Hello, sir. Good evening.
Dr. Ratan Gupta.
Hello, sir.
Dr. Ratan Gupta is a leading consultant, senior consultant in the Narayan Vodhyalia group of hospitals at Bommasandra. He is very knowledgeable and experienced. I'm happy that we'll be having a useful interaction with him at the end of this session. Second moderator panelist is Dr. Shabnam. Shabnam is again a promising and bright intensivist working in the city of Bangalore. Thank you so much, Shabnam, for joining us. And Dr. Mahantesh, would you like to say hello to my colleagues on the screen?
Hello, sir. Hello, everyone.
Mahantesh is a very bright intensivist who was actually he's working with us, but he's offshore now. He's working in Cayman Island for a short time, and I think he will be back to us after some time once he establishes the center. The new hospital is coming up there. And thank you, Mahantesh, for being with us. And I would like to welcome all the panelists, one after the other. Dr. Anoop. Dr. Anoop is here.
Yes. Good evening, sir.
Dr. Anoop Warrior would like to introduce yourself, if you don't mind.
Sure. I'm an infectious disease physician and I'm practicing in a hospital called Aster Medicity in Kochi.
Super. Thank you so much. Next is Binil Matthew. Binil, will you please introduce yourself?
Good evening, sir. I'm Dr. Binil Isaac Matthew, working as a cardiac anesthesiologist in Jubilee Mission Medical College, Thrissur.
Thank you so much. Thanks for joining us. Dr. Ram Kumar, would you like to introduce yourself?
Good evening, sir. I'm from Trichy, Dhanlakshmi Srinivasan Medical College. I'm a cardiac anesthesiologist here.
Thank you, Ram, for joining us. Next in the list is Dr. Shibu. Shibu, will you please introduce yourself?
Sir, good evening, sir. Dr. Shibu here. I am a Chief Cardiac Anesthesiologist of Jubilee Mission Medical College. I am the medical superintendent of the medical college, sir.
Thank you for joining us. Thank you so much.
Thank you, sir.
Next will be Dr. Vikram Va. Vikram, will you please introduce yourself?
Good evening, sir. Hello.
Yes, we can hear you. Please talk.
I think video is probably off. Good evening, everybody. I am Professor Vikram Va at AIMS Gorakhpur, Professor and Chief and Associate Dean Research. Thank you for giving me an opportunity to interact with all.
Thank you, Vikram. And now next one is Dr. Vinay Kulkarni from Nagpur. Dr. Vinay, would you like to introduce yourself, please?
Good evening, sir, and everyone. It's my pleasure to be here in the part of this discussion. I'm a practicing anesthesiologist and intensivist, doing both cardiac as well as non-cardiac cases and covering 2 intensive care units. We work together as a team. We have got 4 anesthetists, intensivists who manage as a group. Thank you, sir.
Thank you for joining us. I think we have the panelists are from all over India, and thank you so much for joining us. So we would like to get a wholesome information about how to manage sepsis from each one of you. So what I have done is I have 12 questions, two questions for each of the panelists, and I would like to request the moderators to comment on the response at the end of each question, as I mentioned their names. And at the end of the 12 questions, we'll open this for the audience chat box as well as for the panelists if they want to add anything or clarify some other thing which was not clear, etc., can be done during that time. With that short introduction, I'll try to share my screen now, and I hope it works. Can you see my screen?
Yes, sir.
Is it coming well?
Yes, sir, it's coming well.
And what happens now?
It's in full screen mode, sir.
That's great. As I already mentioned that the sepsis is a global problem, and the once septic shock sets in, the mortality rate is as much as 50 to 60%, and we need to address this issue in a very, very prompt manner, just like what you do for acute myocardial infarction or acute stroke, what is called as golden hour. We need to react immediately and recognize the problem and start the resuscitation and whatever is to be done as soon as possible to be able to salvage the situation. So first question is to Dr. Anoop Warrior. Dr. Anoop Warrior, would you like to define sepsis? And let's also know what do you mean by VAP, CLABSI, COTI, and SSR.
Thank you, sir. Good evening, all. So to start with, sepsis is now defined as a dysregulated host response to infection, which has resulted in a life-threatening organ dysfunction. So what we need to is underline two important terms. One is that life-threatening or a specific organ dysfunction is mandatory to identify and label as sepsis. And two, the pathogenesis has now been attributed predominantly to dysregulated host response. This may be triggered by an infection, but end of the day, the further worsening, etc., is due to the host response. This is specifically important because to understand, especially when there is failure of antibiotics. Hyperperfusion and requirement of inotropes makes it septic shock. Lactate levels are important because they indicate hyperperfusion at cellular level, and it has been associated with poor prognosis. That's why it's important to look at the lactate. Now, coming to the definitions of the device-related infections, one thing starting is that you should not get confused at all between surveillance definition and clinical definitions. What the infection control team and infection control nurse and ICUs look in your ICUs would be surveillance definitions. So that will be ventilator associated event and central line associated bloodstream infection, CLABSI. While as a clinician, what we want is clinical definition. So as per the clinical definition, it will be VAP, ventilator associated pneumonia, or catheter related bloodstream infection, or CRBSI. So clinical definitions are obviously meant for diagnosis and treatment. Next slide, sir. Now, the VAP is diagnosed clinically with the CPIS score, the clinical pulmonary infection score, which I am sure most of you are familiar. We'll just take a look at that also. While the CRBS is diagnosed with the blood culture alone, that means a paired blood culture, one from the line and one from the periphery, or in situations where the line can be removed with the line tip culture also. So this is a snapshot of the CPAS where you look at the blood pressures, WBC count, the quality of the tracheal secretions, new onset pulmonary infections, worsening of hypoxia, and if you have the microbiological culture, you add it. If the score amounts to more than equal to 6, that would mean that the pneumonia is there, and we would start antibiotics based on that. Next slide, sir. Now, the CRBSA diagnosis, as I mentioned earlier, you can do it by two ways. If it is paired blood culture, that means one through the central line and one through peripheral, look at what is called as DTP, that is differential time to positivity. The blood culture drawn from the central line will turn or bleed positive 2 hours or more than 2 hours before the peripheral blood culture. So the culture from the central line will be positive first, and the blood culture from the peripheral line will be positive only 2 hours or later. So that's paired blood culture. Or along with the peripheral, you can send the catheter tip, which rarely we do nowadays. If at all that is the practice, the catheter tip would be cultured using a semi-quantitative method, and they would report more than 15 CFU per ml. So this is the diagnostic modality for CRBSI. And finally, coming to COTI, COTI is a diagnosis of exclusion. This is because the signs and symptoms are very non-specific in an ICU patient on catheter and ventilator. Hence, you rule out other sites of infection. Pyuria is not relevant. So that's something to be looked at. Don't rely on pyuria at all. Pyuria can be there just because of the catheter present inflammation itself, or pyuria may be absent. So urine culture is a necessity to diagnose COTI. Pyuria is not required to diagnose COTI. And third, that it is a diagnosis of exclusion, meaning you rule out everything else and then you lab down a COTI, because it's usually not that common. So that concludes my short review of the device-related infections.
Thank you so much for that succinct reply. I really appreciate your answer to the point in it, and also I appreciate that you mentioned that the culture from peripheral line takes longer time to reflect in the actual growth in your cultures. Thank you so much for that point. Ratan, would you like to add anything to what has been said regarding
I think
this aspect? Only
just a few points.
this question. Yes, yes.
Yeah, it was a very lucid presentation and very clear.
Yes.
I totally agree that urinary tract infections are pretty uncommon in the ICU setup, and it has to be an exclusion diagnosis by excluding all the other infections. Only thing is sometimes we do combine it with the ultrasound. Make sure that when you have a urinary tract infection, it's not responding. Rule out an obstruction somewhere like in the ureter. Is there a hydronephrosis? That really can complicate the treatment aspect, and you may have to involve the urologist for that. And of course, VAP is one of the commonest type of infection in the intensive care, and you have to go by clinical methods. And whenever someone is on a ventilator for a long period, the secretions do get infected, and in intense context, we do see very often that it's gram-negative organisms.
Right.
Gram-positives are not very common. And any patient who's long-standing, of course, I think fungal infection is another thing which can set in.
Yes, yes. That leads to the second question. Dr. Binil, Binil Matthew, would you like to mention what are the majority of infections due to? I mean, say, what are the organisms which are involved in majority of the infections?
Thank you, sir, for the question. Surgical site infections are among the most common infections during the post-operative period.
Right.
This causes usually by gram-positive bacteria like Staphylococcus aureus or Streptococcus species. Another commonest infections are respiratory infections, because critically ill patients are usually intubated and ventilated during the post-operative period. So the organisms caused so these patients are usually prone for ventilator-associated pneumonia. So the organisms caused are gram-negative organisms like Pseudomonas aeruginosa, Klebsiella pneumonia, or Escherichia coli, as well as the gram-positive organisms like Staph aureus, Staphylococcus aureus, which includes MRSA, that is methicillin-resistant Staph aureus. Another group of infections are, as you told just now, urinary tract infections, which is commonly seen in catheterized patients, and the organisms caused are E. coli or Klebsiella species or Enterococcus species.
Yeah.
Another type of infections are bloodstream infections, which is usually associated with central lines or invasive devices, which is used during the surgery or during the postoperative period. And the organisms caused are Staphylococcus species or Enterococcus species or fungal infections. So talking about the fungal infections, again, which is less commonly seen in these patients, but the patient with a prolonged hospital stay, diabetic patients, or patients receiving immunosuppression therapies, or critically ill patients receiving prolonged antibiotic therapy, these patients are prone for fungal infection, especially like Candida species. Then endocarditis, which is rarely seen in these patients, especially patients with pre-existing valve diseases going for a cardiac surgery, and organisms caused are a breeding group of streptococci or staphylococcus. Then comes the gastrointestinal tract infections, usually caused by Clostridium difficile or other abdominal infections, usually caused by Escherichia coli or Klebsiella. So these are the soft tissue infections. Yeah, soft tissue infections usually caused by Staph aureus or Streptococcus species. So these are the common infections usually seen in these patients. So patients those who are going for a major surgery or patients with pre-existing diseases are there. They should screen for multi-drug resistant organisms like methicillin-resistant Staph aureus, vancomycin-resistant enterococcus, or extended spectrum of beta-lactamase producing organisms, and carbapenem-resistant enterobacterias. The strategies we can adopt are for decolonization. We can adopt for MRSA. We can use intranasal mupirocin or chloride stream washes. And for vancomycin-resistant organisms, enterococcus, we can use again intranasal mupirocin or even an oral antibiotic we can utilize. Next slide, please.
Thank you. Thank you for that. The WHO has warned that superbugs, that is, those are multi-resistant microbes, are the leading cause of death. And in 2050, it is predicted that they will be ruling the roost unless we take preventive steps. Some of the superbugs are mentioned here. And the next question goes to, before that, I would like to request Shabnam to, to give her insight into the previous reply.
Thank you, sir.
Thank you. Thank you so much.
Thank you, Dr. Binil. That was a very informative presentation. One of the only things I'd like to add here is that while cultures typically took 24 to 48 hours for us to get a report, the newest weapon in our armamentarium to detect multi-drug resistant bacteria is genetic PCR testing. So this gives us reports within a couple of hours, and especially in the ICU, it's absolutely vital that we have a fair idea, because it tells us not just the drug resistance bacteria, but now with the newer modalities of genetic PCR testing, we also have the resistance genes picked up. So even though you don't get a culture sensitivity, you still have a fair idea because of the presence or absence of these resistant genes. So that has added a lot of value to our work while dealing with sepsis in an early and effective way.
Thank you. Thank you, Dr. Shabnam.
Thank you.
The next question goes to Dr. Ram Kumar. What are the most reliable clinical indicators of sepsis in a patient? How do you differentiate sepsis from other causes of post-operative systemic inflammatory states? Sometimes on physical examination, patient may have a bit fever and some bit of tachycardia, maybe tachypnea. Sometimes the differentiation between the usual response to an insult and actual infection, how do you differentiate, and what is so far?
Sepsis, good evening, sir.
Yes,
sepsis is a life-threatening syndrome resulting from, as already told, is a dysregulated immune response to an infection leading to organ dysfunction. Early intervention in sepsis improves the survival rate. Any delays in the initiation of treatment leads to rapid deterioration and high mortality. So now let's look into the key clinical indicators that can help us identify the sepsis early. The vital sign abnormalities are fever or hypothermia, tachycardia, tachypnea, hypotension that signal a systemic response to infection. Neurological changes include altered mental status, agitated and confused patient, reduced GCS, indicate possible sepsis-related encephalopathy. Persistent hypotension or hypoxemia and respiratory failure suggest severe sepsis progression. Oliguria, rising creatinine, thrombocytopenia, and elevated lactate-like metabolic values reflect worsening perfusion and organ dysfunction. Given these indicators, how do we quantify the sepsis, or it is simple SIRS? Here, where three things come into play. First thing is clinical, high index of clinical suspicion by the clinician. Second thing, biomarkers, which will be discussed in the later part of this discussion. Third thing is, usually SIRS starts subsiding in another 24 to 48 hours. It is always culture negative, and the patients usually in the mostly I am working in the cardiac surgical setup. In the second post-operative day, they start improving if it is simple SIRS due to the cardiopulmonary bypass, etc. The sepsis usually deteriorates without the proper antibiotic initiation, and it progresses without any this thing even after 24 to 48 hours. Next thing is, given these indicators, how do we quantify and track the severity of the organ dysfunction and sepsis? That's where the SOFA score comes in. SOFA score definition is, SOFA score is sequential organ failure assessment score that helps us the severity of organ dysfunction in critically ill patients with sepsis. It evaluates 6 organ systems, which is respiratory, cardiovascular, hepatic, coagulation, renal and neurological systems. Each system carries a score from 0 to 4. So the total score ranges from 0 to 24. A higher SOFA score correlates with increased mortality risk and guides the treatment decision. The one drawback of this SOFA score is it is designed for population level decisions, not for individual patient level decisions. So it is for individual patient mortality risk, this score has limited usage. Even with patients with higher SOFA scores on initial presentation may improve with proper source control and antibiotic initiation. And another thing is it requires laboratory values, making it less practical in the non-ICU settings, and it may not detect the early sepsis changes. It comes into play once after the organ dysfunction sets in. So the early sepsis changes cannot be detected by this SOFA score. For quick bedside screening, we can use the score called simplified QSOFA. QSOFA is the simplified version of SOFA score for non-ICU settings. The key parameters are respiratory rate more than 22 per minute, systolic BP of less than 100 millimeters of mercury, and altered mental status. This score is quick and easy to calculate and helps us identifying in high-risk patients earlier in a non-ICU setting. This is less sensitive than SOFA for predicting the progress of infection and sepsis.
Thank you. Thank you, Dr. Ramkumar, for that good, excellent reply. I would like to request Mahantesh to give his opinion now that the guidelines I have recommended against use of it so far compared to NEWS or MUSE as a single screening tool for sepsis and septic shock. Dr. Mahantesh, are you there?
Yes, sir. Thank you for this opportunity. Well presented, slides on risk stratification in sepsis. It's very important that sepsis has to be picked up early. Once the sepsis progresses to septic shock, we know the mortality doubles up. So the whole crux or the impetus is to pick up sepsis early. And yes, there are various scores depending on, the data wise, yes, uniformity would help in both in terms of research as well as, ease of doing it in various institutes. Some of the scores that people normally do is Apache 2, Apache 4 has come now. So far, these are all more suited for emergency setup and ICU setup. Quick SOFA, what we call as where we don't, it's just a clinical based assessment, very good tool, and a lot of data now available for its usage in ward level care. So which the nursing team or the rapid response teams commonly use to pick up early signs of sepsis. This has gone a very long way in picking up sepsis early or infections early, and thereby reducing the mortality significantly. So quick SOFA for ward level or what you call less intensive monitoring wards, and SOFA or Apache for emergency and ICU are ideal risk stratification models.
Thank you, Mahantesh. Next question is to Dr. Shibu Pillai. Shibu, what is the role of biomarkers, especially with regard to procalcitonin, CRP, in diagnosis of sepsis?
Good evening, sir. Good evening, everyone. It's an interesting question. It's a life-threatening situation. We all know that. So when sepsis comes, we don't have time. So biomarkers are very, very important. Very, very important. There are nearly 250 biomarkers are tested worldwide, in which most commonly used is the procalcitonin now. Procalcitonin is a peptide precursor of calcitonin. And this is any bacterial infection comes, this started appearing in the blood in 3 to 6 hours of time. And it peaks in nearly 24 hours. And the severity of the sepsis is directly correlates with the amount of procalcitonin in the blood. This used to help us to guiding antibiotic therapy. And there is a serial monitoring what we do. We do every third day monitor the procalcitonin level. So already our previous speaker talking about clinical scoring system, SOFA score. If a SOFA score goes more 2 or more than 2, the patient comes in your ICU. So what we do is, as our Dr. Shabnam told, we do a PCR testing and procalcitonin and culture we will send. And this will along with the clinical scoring system, we can improve the diagnostic accuracy, sir. So this will be really helpful in antibiotic stewardship program. So the serial monitoring is very important. So if the level is coming down after initiation of therapy, it is good. So there is your infection is getting treated well. If the level is going up and your SOFA score is high, you are in trouble. So we have to think about some nosocomial infection or MDR, or we have to further evaluate the patient. Like that, CRP also very important biomarker. CRP normal values around 0.8 to 3 milligram. We were doing a lot of CRP in our COVID time. CRP is secreted from the liver, and any liver dysfunction, CRP level can go wrong. But in procalcitonin is secreted from the renal system. The level can go high if there is any renal failure. And if you do a hemofiltration or dialysis, again, the level can go down. Then another important biomarker nowadays coming is interleukin-6. Early we are using CRP, and then we were moving to procalcitonin. Now the new one coming up, it is interleukin-6. This recently became popular. Another important biomarker is SUPAR, soluble urokinase plasminogen activator receptor. This is also promising. Procalcitonin level is directly correlated with the survival. So serial monitoring is very important, and improve diagnostic accuracy with the clinical scoring system. Thank you.
Thank you, Shibu, for that excellent reply to this question. May I request Dr. Ratan to give his input on this matter? Actually, the recommendation number 6 in the recent guidelines says that they suggest against the using procalcitonin plus clinical evaluation in deciding when to start antimicrobials. What is your take on this?
I think it was quite a lucid talk. What we practically do in the intensive care is we take a overall view, clinical plus the routine CBC testing, the organ-specific indicators like lactates and also the renal function. And the platelet counts, all these things give you a clue whether the patient is heading in the right direction or not. And depending on the clinical plus the investigation, this thing, I think you get a fair idea what is happening with the patient. But the negative part is, especially because SIRS is there, and especially during post CPB, we do see procalcitonin levels going up, though the patient may or may not have infection. So there we have a little bit of struggle. We do check procalcitonin in between so that we can see what is the trend. If, as Dr. Shibu was mentioning, if the trend is downwards, it helps. But if it is a particular number and you're not checking it serially, then it may not really make a difference. And of course, I think there's no doubt that it helps in limiting the antibiotic usage. And you also know when to stop the antibiotics. I think that is a major role where there's no disagreement. CRP is very non-specific. PCR definitely yes. I think it's helping, and it's quite specific, so it helps.
Thank you, Ratan. I take your points. Your points are well taken. Now, next question goes to Dr. Vikram. What are the components of early cold directed therapy, and do you actually believe in early cold directed therapy in sepsis management? Dr. Vikram, you might have to unmute your microphone.
Hello. Good evening.
Yes.
Good evening, everybody. This early goal-directed therapy was introduced way back in 2001 by Rivers in New England Journal of Medicine article. And after that, it has picked up very nicely because it is giving you the fixed targets regarding our therapy. As my earlier speakers have told already, that early recognition and source control is very important. And then we are supposed to get the blood cultures before starting the antibiotic. And as far as possible, broad spectrum antibiotics should be started within 1 hour. And this can be reviewed once we get the blood culture. And now we are getting the blood culture report, a temporary report in within 4 hours also. The systems have been developed. And that the trade name is the backtack, it is coming. Then we are supposed to identify and control the source of infection. For example, surgical debridement is required, drainage of the abscess is there, or if we know that urosepsis is there, all these are supposed to be taken care of. And then we are supposed to initially, the fluid resuscitation consists of 30 ml per kg of the crystalloid. That is usually ringer lactates or normal saline. However, in the diabetic patients, we have to be a little bit careful because this ringer lactate can increase the blood sugar level. And along with that, because patient is already in the stress condition, so the sugar level also may be high. That we have to see. Then secondly, that says some clinical tests are there, like passive lag raise test, then stroke volume variation if you have the monitor available. And it's very simple. The focus we can do to find out whether the IVC is collapsing. If the IVC is collapsing, then we have to give more fluid. And then the vasopressor therapy we are supposed to start. The target is that more than 65 millimeters mercury we should have the blood pressure. And initially it is the norepinephrine in the dose of 0.01 to 0.1 microgram per kg per minute, first line vasopressor. And if it is not responding, then we have to start the vasopressin up to 0.03 units per minute, or we can add the epinephrine if additional support is required. Again, in the dose of 0.01 to 0.1 microgram per kg. And if the patient's cardiac output is low, the ejection fraction is low, then we can start the dovitamin in the range of 5 to 20 microgram per kg per minute. And at the same time, we are supposed to oxygenate the patient and ventilate the patient. But the oxygen saturation is not supposed to go up to 98% or 100%. Anyway, that is up to 92% is valid to avoid the hypoxia. Otherwise, the free radicals are released and the more damage can be there to the patient. And whenever possible and indicated, we can intubate the patient and provide the mechanical ventilation. And target lung protective ventilation strategies are there. Low tidal volume around 5 to 6 ml per kg body weight. And permissive hypercapnia can also be allowed.
Thank you, Vikram. What is your view on early goal-directed therapy? Do you think
earlier when it was started, it was there, but now the something new term has come. That is the perioperative goal-directed therapy. That when we are doing it, because the search criteria are there, the systolic blood pressure that is less than 90 millimeters mercury, or if the lactate level that is also supporting. So we should have the serial ABGs around 4 to 6 per hour. And then we are supposed to assess the patient once again. And then this is the actually slide that was given by the reverse that just now I told. So they are telling that the CEP should be 8 to 12 millimeters of mercury, mean arterial pressure more than 65 millimeters mercury, and urine output in the range of 0.5 ml per kg per hour, or we can say 0.5 to 1 ml per kg per hour. And at the same time, the SCVO2 monitoring continuous, that is very, very important. And these are the goals that they have decided. The hematocrit should be more than 30%. The SaO2 should be more than 93%. And we are supposed to monitor the cardiac index and the VO2 also, as far as possible. And the vital signs and lab data are obtained every 12 hours for the next 72 hours. And then we are supposed to follow up the patient. This is what they have decided.
Thank you, Vikram, for that reply. May I request Dr. Shabnam to tell us what is the status of early goal-directed therapy in the current scenario of sepsis management?
Yes, thank you so much, sir. Thank you, Dr. Vikram. That was clear and concise.
So nice
In the
of you, madam.
ICU, Thank you, sir. In the ICU, I think it is one of the greatest things that has changed over the last 1 or 2 decades is the use of the ultrasound, like you said. It is the most effective bedside tool that we use to actually direct our hemodynamic and resuscitation goals. Like you mentioned, the IVC collapsibility, we look at the velocity time integrals, we look at B lines for pulmonary edema, we look at LV collapsibility, we look at the EF and all of that just at the bedside right there with the ultrasound and the echo. So that has really changed our assessment, because things like velocity time integral and all can actually tell you how the response is to the fluid boluses that we give as well. So that has really helped us in the clinical and bedside uh, guidance to how much fluid resuscitation we should do, and especially in septic patients. So that has changed the scene in a big way. And apart from that, absolutely lab variables like lactates and blood gases and all of those have to be monitored. We don't use central lines that frequently in the ICU anymore, because we have much better non-invasive methods, like I said, with the ultrasound and the echo. So that has helped us in a big way. Thank you, sir.
Thank you, Shabnam. Thank you so much. Do you do this early goal-directed therapy in your patient in ICU?
So we don't follow the exact guidelines of early goal-directed therapy, but the fundamental points remain the same. Of fluid resuscitation, making sure there is source control, antibiotics are given on a priority basis, cultures are sent, lactates are monitored. By and large, the broad parameters remain the same. The exact targets of only this much is not what we look at. Yes. Thank you.
Thank you, Shabnam, for that. I request Vinay to reply to the next question. Some of the points were covered, but you can, in a brief manner, mention about what are the strategies employed to support cardiovascular system in sepsis.
Thank you, sir. Good evening, everyone. Thanks, Vikram, for covering it quite lucidly. Just to continue in the same fashion, when we have a diagnosis of sepsis and septic shock, it's really a medical emergency. And we have to realize that we have to do the resuscitation as aggressively as possible. Now, the guidelines say that we start with fluid resuscitation 30 ml per kilo. I think it is important to look at how this 30 ml per kilo has come, from where it has come. Majorly, it has come from prospective or retrospective trials, and they looked at how much fluid was given on an average to resuscitate patients. So, but that may not apply to all the patients which we are handling. Many times we get patients from outside the hospital, from a different hospital, well resuscitated. So we have to assess the patient individually. We do not fix up ourselves on 30 ml per kilo, but we do assess the volume status by various parameters, by various indicators, either passive leg raising or whatever which have been just mentioned, covered. We can have echo as well. But the point is we have to resuscitate the patients well. Even if they have been well resuscitated, we need to identify whether they have got any fluid deficit, whether they are fluid responsive by using the dynamic parameters, and also assess the lactates. So lactates may be risen because of various other reasons as well. So we need to differentiate between the causes, sepsis causes, as well as from non-septic causes of raised lactate. So that's about the fluid therapy. In terms of what kind of fluids, will come to that. But basically, when we are managing a septic patient, we need to understand, focus on our goals. What are our goals? The goals are getting a mean arterial pressure of around 65 and above. Now, what if the patient is hypertensive and having a chronically elevated blood pressure as a baseline? But research has shown that we don't have to push up the MAP by giving too much of inotropes or vasopressors. As long as we are getting a MAP of around 65 and above with fluid therapy and vasopressors on a smaller dose, we are okay with that. And most importantly is, what are we monitoring? In terms of monitoring, CVP monitoring is no longer practiced. We follow all the dynamic parameters. In terms of blood pressure, it is recommended to have an arterial monitoring in place that will help in sampling as well as supporting your cardiac output assessments as well as your fluid resuscitation. So in terms of administering vasopressors, the choice of vasopressors becomes, it is very clear now, noradrenaline rules the top. We no longer use dopamine, dobutamine, etc. So if, as discussed earlier, if the requirement of noradrenaline goes beyond 0.2 mics per kg per minute, then we kind of add vasopressin or a fixed dose on that. In situations where we have a possibility of low cardiac output, we may add a touch of dobutamine to that or adrenaline. So these are the choices of inotropes or vasopressors available at the bedside. There is no recommendation of other newer inotropes like um, methylene blue or phenylephrine or any other new drugs have been tried, but then they have not jumped into the guideline. So we are left with basic noradrenaline only, and as well as support with dobutamine or epinephrine. In patients with shock, getting getting vascular access is important. Even if we don't have a central venous access, it is important to establish inotrope or vasopressor therapy from a peripheral arterial, from a peripheral line, venous line, as proximal to the body as possible, and get over to the central line as soon as possible. So we should not defer the use of vasopressors for the lack of a central line. We start with the peripheral line and get the central line as soon as possible. So this is the table regarding how to proceed with that. If cardiac dysfunction, we switch on to dobutamine and epinephrine.
Thank you. Thank you. Yes, the current guidelines recommend that central access is not available. You can start the vasopressor peripherally, and you can establish central venous access as soon as it is possible, but you should not delay the starting of the vasopressors. I will request Dr. Mahantesh to respond to this question if he has anything to add on to what has been already said about hemodynamic management.
Yes, sir. Thank you. Very nicely put in terms of hemodynamic resuscitation in sepsis. One need to understand that sepsis is a distributive shock, so they do need fluids. How much is again debatable, but the guidelines are very clear. You can give up to 30 ml per kg, but there has been a paradigm shift from how we used to look at sepsis during our training, like say 15 years back, where my professor used to be very reluctant to start inotropes till adequate fluids have been given. But there has been a shift now. So now the recommendation is more towards using both of them concurrently. You don't have to wait till the fluid resuscitation is over. That is why the recommendation of starting the pressors peripherally has come up. So one needs to be very careful use of some of these pressors peripherally. If you're using drugs like metronidazole, mephentermine, or phenylephrine, that is pretty okay for peripheral use. But if you're using drugs like noradrenaline, make sure that the dilution for peripheral use and the central use is different. So one should note that. Second, I think there is more impetus to use the pressors early on, more concurrently with fluid resuscitation. That has been a kind of a shift. The shift has come forth after the concept of de-resuscitation. So you need to remember that whatever fluids you give, ultimately you need to de-resist them once they're more stable. So more they get fluids, that probably, the studies have shown that, the overall and what you call a cumulative fluid balance, positive fluid balance has a detrimental effect in outcome. So that is why there is more impetus now to look at dynamic parameters of fluid assessment rather than a fixed recommendation of 30 ml per kg. So you look at dynamically how the patient is responsive to preload and try to resist them concurrently with some pressors on board as well.
Thank you, Mahantesh. When you talk about crystalloid infusion, do you give a normal saline or is it balanced salt solutions?
Right. Again, this debate, I think, has been adequately addressed in many of the researches which have been published. So definitely for Indian setup, crystalloids are now good enough. So there is no further advantage using crystalloids. Whether you use normal saline or balanced crystalloids like ringus lactate or plasmalite, should be okay to use both of them, but you need to still understand that over usage of normal saline has its own detrimental effect in terms of hyperchloremic metabolic acidosis. But other than that, I think both can be used depending on the availability. In certain phenotypes of sepsis, like say we have endothelial, extensive endothelial injury. Normally we see in India with tropical infections like dengue, where there is endothelial injury leading to leaky syndromes. You have to be a little careful in using crystallized. There may be a role of early use of colloids in them, so that is something people should keep in mind. So it's more personalized than generalized. Yeah.
You did mention about colloids. Which colloid would you like to do?
Normally in acute care setting, we use albumin because the others may affect in various organ issues that these sepsis patients have. So we use either 5% or 10% albumin. Yeah.
Thank you, Mahantesh. Now we go on to the second round of questions that goes to Dr. Anoop Warrior. Dr. Anoop Warrior,
yes,
could you please tell us something about choice of antibiotics?
Sure.
How do you select empirical antibiotics?
Can you go on to the next slide, sir?
Yeah.
So in terms of the selection of antibiotics, predominantly it starts with identifying the clinical syndrome. So are you treating a VAP? Are you treating a CRBSI, a possible COTI, or is it a skin soft tissue infection, etc.? So once you have fixated on what is the clinical syndrome, next is to understand your own ICU epidemiology and have an idea of what is the prevalence of MDRs. If you have very high carbapenem resistance, then you need to think of a carbapenem resistant bug which to cover. Otherwise, mostly we go on with carbapenems itself. The second thing which we consider is also the site of infection, because we need antibiotics that will penetrate. So if you're treating lung infections, you would not use colistin nowadays because you've got drugs which penetrate into the lung better, like the beta-lactam inhibitors. And finally, you would also take into consideration if you want to cover or consider unusual pathogens like Candida or Aspergillus, because in your usual empiric cover, it is not so. So we do a risk assessment for fungi. We do a risk assessment for MDR and also carbapenem resistance, and look at the site of possible infection and decide the antibiotic would be most appropriate. Can you go to the next slide, sir?
Yes.
So in terms of the choices, we also consider the appropriate dose because of a lot of the volume change distributions in the critical yield in terms of also renal replacement or the distributory shock itself, which changes the volume of distribution. We go for a slightly higher dose in the first 24 to 48 hours to ensure that the bactericidal effect is there. And once we are able to isolate a pathogen, we stress on the de-escalation also. We have reasonably good data to suggest that culture targeted or driven antibiotics or de-escalation is safe to practice.
Yes.
So just to summarize, understand your epidemiology, choose drugs as per your epidemiology, look at what syndrome you are treating because the drug needs to penetrate into the syndrome. So in the clinical practice, this is the most common scenario. If you have very low prevalence of CRE, drug-resistant Pseudomonas aeruginosa or Acinetobacter, we go with carbapenems. Like one of the previous speakers also was mentioning, hospital-acquired infections from MRSA are very unusual in our setting. So usually we don't add MRSA cover unless it is a suspected CRBSI and your ICU has high prevalence of methicillin-resistant staph epidermidis, which causes CRBSI, then you would add some teicoplanin or vanco. If you have high prevalence of CREs or carbapenem resistance, then polymyxins with or without carbapenems would become the drug of choice. There are sometimes outbreaks or pockets of infection with non-fermenters like Burkholderia, Stenotrophomonas, etc., where minocycline has a role. And as I told you, we screen for risk of candidemia being the third or fourth biggest cause of bloodstream infection in ICU. Based on this patient severity, we go upfront with either an echinocandin in a shock or a severe patient, vis-a-vis fluconazole if the epidemiology in your ICU allows for it. Timing also, just to conclude, the timing is also quite important. We spoke about the golden hour. So this algorithm gives you that onset of shock means and suspicion of this thing means you need to act fast. You administer antibiotic almost immediately within an hour once you draw the cultures. If shock is absent, patient is hemodynamically stable, you have a window of opportunity to evaluate, identify the site of infection, maybe do an X-ray or do an ultrasound and ensure that the antibiotic gets into within the first 3 hours.
Thank you so much. Thank you, Anoop, for that. Dr. Ratan, do you want to comment on this issue?
Yeah, that was a wonderful discussion there, and um, I totally agree with what Dr. Anoop mentioned. There are some lacunae we see in the intensive care, like means the nurses are so busy with the treatment and taking care of the patient. Sometimes they may fail to do the basics like checking a temperature. Uh, the only time we recognize that patient is going septic is because of hypotension and things. So I think sticking to the basics and having a close watch on the vitals, including the temperature, should be prioritized. And of course, the antibiotics we have a very limited repertoire there. So we have to use it judiciously. As Dr. Anoop mentioned, taking cultures before starting the antibiotics is the totally important thing. And over the last couple of decades, what we have been seeing is the multi-drug resistant organisms have definitely gone up. Early 2000, we were seeing a lot of sensitivity to carbapenems, which is not the case nowadays. So depending on the other thing I want to mention is using of imaging technologies, including ultrasound, CT scan, may help you to identify which is the source of infection, so that you can target the antibiotic specific to the organ. So these are a few things I just want to highlight. So we have been seeing a lot of Candida auris recently, especially in patients who are immunosuppressed, who are long stayers, who have been on multiple antibiotics for extended period of time, like 2 weeks, 3 weeks in the intensive care. So that becomes quite difficult to treat and salvage this kind of patients. And cross infection becomes significant as well in these patients.
Right. Thank you for that. And we'll move on to the next question in the series. Dr. Binil, would you please take up this question? How do you manage respiratory failure? What's the role of ECMO? And what do you think are the indications for renal replacement before renal replacement therapy? Thank you.
Thank you, sir. The respiratory failure in sepsis are maybe due to acute kidney injury, ARDS or acute respiratory distress syndrome, or pulmonary edema, or hypoxemia or hypercapnia. So to assess the severity of the respiratory failure, we need a arterial blood gas, which will help you to evaluate the hypoxemia, hypercapnia, and respiratory acidosis. To find out the cause of the respiratory failure, you need a chest X-ray or a CT chest. Of course, coming to the managing part, you should optimize the hemodynamics. As just now we discussed, we have to do a fluid resuscitation, and if at all required, we can start an anotropes or vasopressors, and we have to control the source of infection. Next slide, sir. Next slide, sir, please. So coming to the treatment part, to treat the ventilation of the oxygenation of the patient, we can start oxygen therapy using a nasal prawns or normal.
Hello, Dr. Binil. Can you hear Dr. Binil?
Of course, we have to be so careful, because in hemodynamic unstable patients, if you are starting a non-invasive ventilation, again, you are increasing the thoracic pressure, the patient may land up in a circulatory collapse. Another option is high flow nasal oxygen, which we have strong literature support for high flow nasal oxygen. We can use it. And if you are not able to manage with high flow nasal oxygen, we have to think about invasive mechanical ventilation. So coming to the indication for mechanical ventilations are severe hypoxemia with the PO2 of less than 60 millimeter of mercury or a saturation of less than 90%. hypercapnia of more than 60 millimeter of mercury, or respiratory acidosis of less than 7.2. With severe respiratory distress, with patient using accessory muscles for respiration, and if the patient is exhausted, we have to consider the invasive mechanical ventilation. Coming to the ventilation strategies, you should use low tidal volume strategies, of course, with 6 ml per kg of ideal body weight. And positive and expiratory pressure, PEEP, should be used to help the oxygenation. And our aim should be to maintain a plateau pressure of less than 30 centimeter of water. And we can use volume control modes or pressure control mode, depends upon the clinical scenario. And of course, you should use lung recruitment manuals in these patients to open up the lung. And if you are not able to manage during in the supine position, of course, we have to think about the prone position ventilation. While you are doing a prone position ventilation, of course, the duration should be it should be more than 12 hours per day. If you can't manage the patient with ventilatory support, full ventilatory support, then we have to think about extracorporeal membrane oxygenation, ECMO. The indications for ECMO are refractory hypoxemia with less than 50 PO2 of less than 50 millimole of mercury, and severe ARDS with intractable oxygenation failure, and patient in cardiogenic shock or a septic shock with hypotension and severe hemodynamic instability. Talking about the ECMO, we have two types of ECMO, that is veno-venous ECMO, which is useful in primary respiratory failures. And if you need a cardiovascular support, of course, we have to think about veno-arterial ECMO. Coming to the next part of the question, that is managing the acute kidney injury management. Acute kidney injury patients. So patients with acute kidney injury, they require a multidisciplinary approach, which includes sepsis control, optimization of renal perfusion, fluid management, and careful monitoring of renal function. So talking about the careful monitoring of renal function, we need to monitor serum creatinine regularly. Also, we have to monitor glomerular filtration rate and urine output. So talking about, thinking about the urine output, so the patient should have a urine output of 0.5 ml per kg per hour. If the patient is having less than 0.5 ml per kg per hour for more than 6 hours, again, that is a key indication for acute kidney injury. So next slide, please. Then you have to think about the assessment of electrolytes, because these patients are prone for hyperkalemia, hyponatremia, and acidosis. Then coming to the optimization of hemodynamics, we have already discussed about the fuel resuscitation and using of inotropes. Also, we have to avoid or minimize the use of nephrotoxic drugs in these patients. Coming to the indications of renal replacement therapy, the key indications are severe or persistent hyperkalemia refractory to the medical management with a serum potassium level of more than 6 to 6.5 millimole per liter, which is associated with ECG changes, are critical indication for renal replacement therapy. Another indication is persistent fluid overload, which is associated with pulmonary edema and cardiogenic shock, is another critical indication. Then comes the next one, that is metabolic acidosis, which is not able to treat with the bicarbonates or other medical therapies. Another one is uremic syndromes with the uremic encephalopathy with altered mental status, or pericarditis, or anti-uremic toxicity. Then another indication is refractory hypotension due to acute kidney injury, which is not able to manage with fluid challenges and inotropes, are another indication. Then comes the last one, that is progressive or severe acute kidney injury, which is not able to, even after the management of maximum medical management 24 to 48 hours, if the patient is not able to manage, then we have to think about renal replacement therapy. About the renal replacement therapy, we can consider a continuous renal replacement therapy or intermittent renal replacement therapy, or you can consider peritoneal dialysis. Depends upon the clinical scenario.
Thank you, Binil, for that succinct reply. May I request Shabnam to add or comment on this reply
Yes.
to the question? Yes.
Thank you, Dr. Binil. That was very, very a vast topic covered in a very short time. But yes, I think for renal replacement therapy, CRRT has been a very useful modality, especially in critically ill patients in septic shock who are not able to tolerate the conventional hemodialysis. One of the things I'd like to add here is the correct antibiotic dosing, depending on the modality of renal replacement that is ongoing. This is a very important point that needs to be looked into, because obviously the antibiotic dosing will be dependent on the renal function of the patient and what kind of dialysis the patient is on, just so that we have the optimal dosing and we don't subdose and contribute to resistance and, of course, the loss of efficacy of the antibiotic for that patient. That's all.
Thank you, Shabnam. And now we move on to the next question in the list that goes to Dr. Ram Kumar. What are the strategies that can be employed to reduce the incidence of sepsis in patients? What do you mean by bundles?
Yes, sir. Sepsis prevention starts with the infection control bundles in our ICU. First thing is ventilator-associated pneumonia prevention bundle. It has several components like content of the bed elevation to 30 to 45 degrees, daily sedation breaks, and checking the suitability of the patient for extubation and mobilization, oral hygiene with chlorhexidine, and using the endotracheal tube with the subglottic secretion drainage to reduce the VAP risk. That CLABSI prevention bundle includes strict sterile and barrier precautions during the central line insertion, using the chlorhexidine for skin preparation, and regular assessment of central line necessity and removing it as early as possible when it is not needed anymore. Party prevention bundle is minimizing the unnecessary catheter use where it is not going to provide any benefit, and ensuring the proper aseptic insertion technique during insertion and removing it as early as possible. This SSI, surgical site infection prevention bundle, which has preoperative skin decontamination with chlorhexidine, timely prophylactic antibiotics. That is, within 1 hour of incision, the antibiotic, broad spectrum antibiotics should be administered, and a strict aseptic surgical technique to lower the SSI. Infection prevention is incomplete without hand hygiene and proper PPE use. WHO's 5 moments of hand hygiene include hand washing before and after patient contact, before any aseptic procedures, before and after the fluid exposure, after touching the surroundings, before getting involved in the patient care. This routine audits, which monitoring the compliance to this hand hygiene and PPE use, ensures the accountability and improves the infection control. The PPE is like gloves, masks, and gowns not only protect the patients from the sepsis, also they protect us from the infection, protect us from getting the infection from the patients. So even with such kind of infection prevention, some cases of sepsis are still occurring. So we have to make necessary steps to ensure early diagnosis of the recognition of the sepsis, and rapid response strategies. The sepsis screening protocols, standardized protocols across the all wards and the emergency ICU settings should help the identify the high-risk patients. And the electronic early warning system, whenever a deranged result pops up, this electronic warning messages can be displayed on the screens in the concerned ICU. And the rapid response teams should be formed, and this multidisciplinary team should provide immediate care to the patient and to prevent the sepsis progression. Then antimicrobial stewardship is the next step. What is this antimicrobial stewardship? It is all about right drug, right dose, and right duration. In principle, antibiotic stewardship is use the most effective, narrow spectrum antibiotic based on the local culture resistant patents. De-escalation strategy is switch to the targeted when starting when we suspect sepsis, we start with the broadest spectrum antibiotics to cover all the pathogens. Once the culture report comes in, we have to switch to the targeted therapy once we identify the pathogen. Monitoring the resistance trends using local antibiogram helps us in guiding the empirical therapy. Beyond antibiotics, the environment, optimizing the ICU environment and optimizing the patient preoperative and optimizing the patient's general status is reduces the sepsis mortality. The few things in patient optimization are glycemic control. We try to maintain the blood glucose levels below 180 in our ICU. Nutritional optimization, early enteral feeding supports the immune function and the gut integrity and reduces the incidence of sepsis. Vaccinating high-risk patients against influenza, pneumococcus, and COVID-19 prevents the secondary infections. Then the most important thing in the cardiac surgical setup is any surgical patient is maintaining normothermia during the procedure. This thing can be added to the perioperative patients in reducing the incidence of sepsis. Then comes the infection environmental control. The routine cleaning of the high-touch surfaces that aids in the pathogen transmission. The use of HEPA filters and positive pressure rooms reduces the airborne infection. After diagnosing the patient with the MDR pathogens, shift him to the isolation rooms. And once he is discharged, thorough room contamination should be done to prevent the spread of infection. The next thing is whatever we do without our staffs understanding that the thing they are spreading the infection, they are caring for the most infected patients. We cannot make things better. We continuously regularly have sessions on sepsis, workshops on targeted towards our staffs every 3 to 4 months in a year. Whenever a new staff comes, she goes through all the sepsis protocol, sepsis drill before coming into the ICU. This is workshops for staffs and educating them is the most important step in the prevention of infections. Then surveillance programs. Surveillance programs can be hospital-wide sepsis tracking, real-time feedback from the healthcare teams, constituting the multidisciplinary sepsis committee, and trying to reduce the incidence of sepsis with the collaboration of all the specialists in the patient care. Thank you, sir.
Thank you so much. That was an excellent coverage of the topic asked from you. Dr. Mahantesh, would you like to add anything to what has been said?
Yes. Thank you, Dr. Ramkumar, for an extensive, very lucidly put presentation on sepsis surveillance. I think we are now moving towards, whether it is sepsis or any other disease, we are more moving towards what we call as multidisciplinary team approach, what we call as MDT. So and in sepsis, it is no different as well. So having a team which comprises of the treating clinician, the microbiology and infection control team plays a huge role. So every unit which treats this sick patient should have audits in place. You audit your bundles on a monthly basis, present them. And very important to do what we call as root cause analysis of where there is a breach in any of these bundles and how we take forward, because These are just a recommendations. These may not fit into a unit, so you'll have to probably tailor make them. So very important that we maintain an active surveillance with active involvement from microbiology, infection control, and the treating team. Yes.
Thank you, Dr. Mahantesh, for summing up the aspect here. And the next question goes to Dr. Shibu. How do you measure and track sepsis outcomes in your institution? And what is the role of anesthesiologists played in this?
Yes, sir. So this is a quite interesting question for me because I am the executive medical director of my hospital, and more than that, I am infection control committee chairman and chief cardiac anesthesiologist and medical superintendent of my institution. My institution is a 2,000 bedded medical college. So I'm happy to answer this question. So first we have to detect number of cases happening in different part of the hospital. So in the hospital, you have to having whatever we have discussed, wound infection may be there, and the WAP will be there, catheter-associated infection will be there, COTI will be there. All this data we will be collecting. And number of patients who is having septic shock and require vasopressors also will be big. And I think that is a burden for the patient and to the hospital. As the previous speaker told, we will ensure that the sepsis bundle, whether it is getting implemented or not, and importance of giving antibiotic for the sepsis early, it's already discussed. And the procalcitonin level and the lactate level based treatment, we will be already discussed, and all these things we will be trying to implement in our hospital, and we will monitor how many patients are having infection. So quality improvement in our institution will be improve early detection and enhance treatment outcome. So improve early detection is very, very important because we have to already discuss the importance of PCR. So what we are planning to implement in our hospital is electronic medical record system. We will be incorporating with our AI system, and there will be early warning sign will be coming from that. Already we implemented MuScore to our nursing workflow. Next slide, please, sir. Next slide, please. Okay, so we will be already implemented in Muse to our nursing outflow. We can implement the SOFA score, whatever to the thing. So PCR testing is very, very important. So we already discussed that, so I don't want to go to that again. And procalcitonin PCR testing, we will get very early, within 1 or 2 hours, we will get the organism. More than that, we will get the antibiotic resistance by doing PCR testing. Procalcitonin also 1 or 2 hours, the test will be available. We can do CRP or interleukins, depends upon the institution. Recently, we implemented interleukin also in our hospital. The MRSA screening and decolonization very well discussed by the previous panelists, so I don't want to go to that. Rapid response team, we already implement, which include infection control team, our infection control specialist, and physicians plus our microbiologists in that team. They will be taking the daily sepsis rounds also. Restricted antibiotic policy, we have to authorize someone, strong person to pre-authorize to give the restricted antibiotic policy. Their signature is there, then only we will be giving the antibiotic. So already we have discussed very well about antimicrobial stewardship program that made making my discussion very easy now. So 4Ds. So already discussed the right drug we have to select. Dr. Anoop Warrior told how you can take that empirical antibiotic therapy, and the right dose, we are already discussed that very well. And right duration, here the prophylactic antibiotic one we started, where surgeons are reluctant to stop it. So they will be continuing more than 24 to 48 hours. That is the problem. We have to monitor and we have to educate them. De-escalation also, we are discussed very well by the previous previous speaker. So here, once it is started responding, these physicians are reluctant to stop that particular antibiotic, broad spectrum antibiotic. So we have to sometimes not only the staff, we have to educate our colleague also for this kind of things. Regular awareness program we have to do. So if you implement all these things, we can come down 30% reduction in the sepsis and 50% reduction in the antibiotic usage, 25% reduction in the sepsis-related mortality. What I want to conclude is, whatever we discussed today, we have to implement our system. That is very important, sir. Thank you.
Thank you, Shibu. Shibu, you made me very happy by saying that by implementing all the things you said, we are going to reduce the antibiotic use by 50%. That will be a great achievement. I'm really delighted to know that. Dr. Ratan, do you want to say anything on this?
I think majorly covered all the topics. Just want to highlight that we need a very dedicated infection control team, including some senior nurses who can assimilate all the data which is available, and then that has to be percolated down to the medical personnel, including the doctors, the nurses who are working in critical areas, even class 4 employees who are taking care of all the shops, disposing the waste. Everyone is important because any break in the chain can lead to a disaster. And we also have someone called as a clinical microbiologist, who is other than the lab microbiologist, who does clinical rounds, and he leads the team of critical care nurses, and also heads the monthly HICC meetings, like what Dr. Shibu is doing in his hospital as a chairman. So I think it's a very important concept, and the data has to be percolated down to everyone, including the residents in all the departments, because they are the ones who are handling things on a day-to-day basis.
Thank you, Ratan. Thanks for that. Next question goes to Vikram. What are the most promising areas of research in sepsis management? What is the role of immunomodulation and precision medicine?
Good evening, all.
Yes.
Though nothing is much concrete about it, but at least some data are promising. One is that there is inflammatory response followed by immunosuppression. So the patients are very, very susceptible for the secondary infection. So immunomodulatory strategies are there that restore the immune balance rather than just suppress the inflammation. Area there, then colony stimulating factors are also there. These all are ability to precision medicine approaches. Like one is there very clear that almost 200 biomarkers are there. One is that say your time tested procalcitonin. Then there are HLA DR expression on monocytes is also there. And then metabolomics and the proteomics. These are identifying the unique metabolic and protein signatures to find out the response to the therapies. Then genomics are there. That is the Mars consortium. That one is the molecular diagnosis and risk stratification of the sepsis. It aims to classify the sepsis into distinct immunology. And then AI is coming in a big way. They are collecting electronic health records or electronic medical records, EMR, and they find out that whether we can detect the sepsis hours before the clinical signs are appearing. So all these data are analyzed by the computer system, and then they have a predictive model. The directed therapies are there that instead of targeting the pathogens, the therapies are focused on enhancing the host's innate immune defense system. For example, the AMPs are there, that is antimicrobial peptides that enhance the macrophage function of the body. So inbuilt immune function is there, that is strengthened. Then there is blood purification and extracorporeal therapies like hemoadsorption devices are there, and these remove the cytokines, endotoxins, and bacterial products are there. Then there is something known as high volume hemoinfiltration system. It can improve the hemodynamics, but it requires they're also in the Then there are the therapies of the hydrocortisone that works by the metabolic resuscitation, though the dose and the duration that is still debatable. But people say around 50 to 100 milligram of the hydrocortisone 2 to 3 times a day, that should be sufficient.
Right.
Also coming in the way, that is immunomodulation plus antimicrobials, which may be needed for the specific sepsis subtypes. That's all. Thank you very much.
Thank you, Vikram, for that lovely response. May I request Shabnam to comment?
Thank you, Dr. Vikram.
Thank you,
This is
Vinay.
a very, it covered all the newer, exciting things that are happening in the sphere of immunomodulation and the role of the newer devices and drugs that are coming in. Like I think Sir has pretty much covered everything in the fact that all of these things are upcoming. It's a very nice time where we are on the brink of having so much of therapy that is directed to a particular patient. And I think we have to wait and see for the evidence to come out for all of these novel therapies. They're very promising, but we need to wait for the evidence to be there.
Absolutely. Thank you, Shabnam, for that.
Thank you.
Next question, Dr. Vinay, will you please let us know the role of artificial intelligence? Actually, it was mentioned in a passing manner in the previous response. What is the role of artificial intelligence, machine learning in sepsis management? And what do you think are the knowledge gaps?
Yes, artificial intelligence, just alluded by Vikram in his previous discussion and everyone. What humans do, we want the artificial intelligence to do it for us. Similar to what we do, like applying ourselves, using our intelligence, learning, reasoning, and decision making. So we want the computers to do it for us, and it may help us to a certain extent. And machine learning is a subset of artificial learning, artificial intelligence, where learning it basically can acquire knowledge and techniques from data and create machine learning models. So how would these help us? They would help us in first is prediction of sepsis, prediction of an event that is happening or that is likely to happen. That would help us in diagnosis. And there is a strong possibility with the coming research that in future we would be able to offer personalized treatment to patients with sepsis as well as non-septic diseases. Like it's already on in other areas like cancer therapy and so many other hematological disorders. So how would artificial intelligence benefit sepsis management? Yes, definitely. There are a lot of studies being projected in the literature about how would they have looked at many retrospective studies as well as a few prospective studies. They've collected electronic records from the patients from the emergency room to the various wards they've traveled into the hospital, and that would kind of collect the data and put up some alerts by gathering the data, say about basically from few data to many parameters. So that would alert the concerned department or put a red flag as to this is a patient likely for sepsis, and that would initiate early intervention, early therapy. So there have been papers in the literature about Nevoy sepsis, sepsis immunoscore, and they have proven that yes, we are able to predict sepsis earlier as compared to human assessments, and it would help us. It will complement our management protocols by applying these artificial intelligence models. So how would it help us? It would help us in firstly diagnosing sepsis earlier. It would help in managing sepsis in terms of uh, how to monitor fluid therapy, how to guide fluid therapy by incorporating eco parameters. In machine learning models, it can also actually see what has been written in the literature by doctors. Sorry, not in the literature, in the notes. So by collecting the points from the notes, it can alert to a higher possibility of sepsis or an event happening likely to happen. So that is how it will it will kind of alert us to a possible event. So that is where we are at the moment. These are all very exciting things, as rightly mentioned, but then it's a long way to go. In future, we are looking at individualized therapy, and but still a lot of research has to come, and we are still at the very bedside. This may not be really applicable at the moment in time. Thank you, sir.
Thank you, Vikram, for that lovely response to the question asked. May I request Dr. Mahantesh to elucidate his views on this?
Yes. So as we are becoming more technocrat, using various gadgets to help us in our personal needs. Similarly, in medicine, obviously the AI is going to come in a big way. How much of it is going to make a difference in clinical outcomes is still a subject of research. But nevertheless, this is going to probably come as probably an augment to our clinical assessment and care. Definitely in high volume centers, in high happening zones like ER and ICU, my personal opinion is that AI is going to make a big difference in early identification and identifying various phenotypes. I think the next probable subsequent sepsis guidelines would be, rather than being general, will be more phenotype based. Currently, they are looking at phenotypes like hyperinflammatory states, hypoinflammatory states, catecholamine resistant situations, low flow phenotypes, endothelial dysfunction as one of the phenotypes. So all of these sweeping general guideline in terms of treatment may not help. One may benefit to a particular phenotype, and the same treatment may not benefit the other phenotype. Now, what is happening in research is everything is offered to every sepsis patient, and that's how we haven't seen any major, benefit with any of these what we see as very logical treatments being offered. But I think in the future, the research will be more towards identifying various phenotypes of sepsis and offering specific treatment for them for that individual group. And I think we'll have to still wait for those research. I mean, the studies to put more light, throw more light into the treatment of these phenotypes. But I guess the AI is going to come in big way to identify basically these phenotypes and help us personalize the treatment.
That's right. Thank you, Dr. Mahantesh. I think we are at the end of the discussion, but before we open it to the chat box, we still have 10 minutes. I would like to highlight the national guidelines for infection prevention control in healthcare facilities as put forth by the Minister of Health and Family Welfare in India. I'll just read it out. The important points are mentioned here. Formulate standard treatment guidelines, hospital antibiotic policy with a multidisciplinary approach using the local antibiogram. This was mentioned in our discussion. Provide ongoing education on rational use of antibiotics, restrict the use of antibiotics. This was also covered in our discussion. Before initiating antibiotic treatment, submit appropriate specimens for bacteriological examination to the laboratory and select antibiotic based on the clinical spectrum of disease, sensitive pattern, patient tolerance, and cost. This was also mentioned. Based on the culture results, Use an agent with as narrow a monitor surveillance, as narrow a spectrum as possible, and carry out periodic prescription audits. This was also mentioned. Use of antimicrobial prophylaxis only when benefit outweighs the risks. Note that antibiotic prophylaxis is not a substitute for appropriate aseptic surgical technique and for other infection control measures. This is taken out from the national guidelines for infection control. And to end the session, sepsis and septic shock are life-threatening conditions associated with high mortality. As I said, it's about 50 to 60% of the patients with septic shock are likely to die. Early recognition and aggressive management is mandatory. Anesthesiologists must take active part in infection control practices, and we should integrate microbiologists, infection control teams, surgeons, intensivists, nurses, and other personnel who are associated closely with the patient care. Thank you so much, and we will go on to the chat box, and any questions are there. I request all of you to switch on your video so that we can see you on the screen. I'm just opening the chat box. The first question here says, is there any role of fumigation of ICU or fumigation of OT in current practice of medicine? Who will take this question? Maybe Shubhu can answer because he has great insight in the management of hospitals in terms of infection. Shibu, would you like to take it? And anybody else wants to answer, please feel free, sir. After
Sir, I'll answer, sir.
Yes.
Latest CDC guidelines from the US says that there is no need for routine fumigation of any patient care places, including the OT, wards, and ICUs. What we need is surveillance. If surveillance comes out with something, then fumigate. Otherwise, routine fumigation is not needed in any of these areas.
Routine fumigation is not needed. What happens if you have infected patient in terms of multi-drug resistant organism, or it is hepatitis B positive patient, which is infective? Then it is HCV.
Then we can do it, sir. Routinely doing every weekend, we doing it, cleaning the OT and fumigating. That is not necessary.
Not necessary.
And routinely, the fumigation of ICUs and wards should never be done.
Okay, so just to add on or sort of clarify,
yes,
is clear what fumigation is aiming to do? Is it disinfection of the air? Is it disinfection of the surface? Is it disinfection of the equipment? Is it disinfection of the floor?
Right.
What exactly are we trying to achieve with fumigation? So the answer to that is that all our OTs and ICUs have the designated air changes per hour.
Yes, yes.
More than 20 per hour, ICUs more than 12 per hour, etc. So it is going to do nothing to your air. Within minutes, that whole air, this thing is going to go, and it is, we know that air is a dynamic thing. So this is not going to do anything for the air. So it is basically an added or an adjuvant to your surface disinfection, something like a thermal conductive surface. So if you are relatively good with your surface disinfection,
yes,
that's all that is required. So fumigation is not for air because that is cleared off by your ventilation. It is only for surface disinfection, and surface disinfection is like it's an adjuvant to your routine, what you call your direct cleaning practices, because we know that just spraying mist over the dirt does not wash away the dirt.
Sir, can I pass a comment, sir?
Yes,
sir,
absolutely, Shivu. We are waiting for your
sir, fumigation is an obsolete terminology, actually.
Right.
It's gone. It is gone. NABH is not recommending fumigation. Fogging is the new terminology we are supposed to use. That is hydrogen peroxide for producing substance we have to use for fogging. Fumigation is gone, sir. Fumigation is gone.
Right.
Okay,
Thank you for the answer is clear. Fumigation is no longer in current practice.
And what about the intensive care? So I think we do fogging in the intensive care, and we try to, whenever we are thin with the patients, we try to empty a wing by wing. Entire ICU cannot be emptied. We do surface cleaning, the AC ducts and other things where the dust can accumulate. We try to clean those, change the screens which are there in between the patients, clean the monitors. So that can be done thoroughly, and defogging is what we do with hydrogen peroxide.
The other question, yes.
Sorry, just wanted to add to what Ratan sir was saying. Very
Yeah.
true, and very good hand hygiene practices amongst our staff. To be able to not touch contaminated surfaces and then touch the patient also contributes to infection control practices. So thank you.
Absolutely, very rightly pointed out. I would like to ask, now there's a lot of talk about capillary refill time. What is the current place of this capillary refill time? And do you think that will be one of the important parameters which we would be using in routine practice? Who was the person who did the hemodynamics?
Sir, capillary refill time
yes,
is coming in a big way. A lot of articles are there, like the capillary refill time is less than 4 seconds, it is good. If it is 4 to 6 seconds, it is mildly impaired, or more than 10 seconds is definitely impaired. And that is what it should be included in the protocol of resuscitation in addition to lactate. But then it's not something which is a standalone parameter. It's a kind of a one of the combined parameters to be assessed. Yes, it is definitely possible. I mean, it's a simple tool, and now we are coming towards objective criteria for assessing that. So that's also coming. Some units are practicing that, and I'm sure. I mean, most of us can do that, but we need to have an objective assessment, not a subjective one.
Right.
In the same way,
may I add something, please?
Yes. First Shabnam, followed by
myself, Vikram.
Yeah.
Just wanted to add the way we had recently the Andromeda trial, the Andromeda shock trials, which were also looking at capillary refill time as an alternative to lactate monitoring. And though the mortality benefit was not there, it may be considered because it's something that can be done regularly at the bedside and gives us a visual clue as to how our resuscitation is proceeding. But I don't think it would be replacing lactates. It's definitely coming up in a big way, and I think we should wait for more evidence to come in.
Yes. Dr. Vikram, you wanted to say
Yes, just what Dr. Vinay and Dr. Shabnam has told, add to that the AHA guidelines 2020, these are also supporting that capillary refill time is one of the indicators, or rather early indicators of the shock. Though it is not the standalone, but it is always an added indicator. And secondly, as far as the infection goes, we should see that the cross infection is also not there in the ICU, because sometimes what happens, we say nurses are in the shots so that we can just allot one sister for 2-3 beds, and they don't wash their hands properly in between the two patients. So that also should be taken care of, particularly the administrators like you and Dr. Chibu, that adequate number of staff is there. And that will be minimizing the infection, and ultimately that will take the salary of those nurses also. Thank you, sir.
Sir,
yes,
I have a question, sir.
Yes.
What is the current place of methylene blue and high-dose hydroxycobalamin in septic shock, rescuing the shock?
Methylene blue and
hydroxycobalamin.
Who will respond to this?
Is the question about use of methylene blue in sepsis? Is that the question?
Methylene blue and hydroxycobalamin.
Okay, yeah. So, I mean, methylene blue is a kind of was there in sepsis for a very long time. It's nothing new that is being used in sepsis. The current studies have shown that, when used in general term, it has not shown any mortality benefit. But I guess in going forward, when we understand more about various phenotypes of sepsis, definitely those with severe vasoplasia resistant to what you call as catecholamine resistant phenotypes.
Yes.
Personally, I have used methylene blue in those cases with some benefit, but as I said, it is just personalized rather than generalized kind of a recommendation at this point. I'm sure as cardiac anesthesiologist, you would see cardioplegic patients, who are resistant, where it's not uncommon that you would use a methylene blue. Those kind of phenotype patients, methylene blue has a role in terms of just to get them out of those low perfusion states. But I guess as a general indication for sepsis right now, in studies, methylene blue has not shown any major benefit, and for that matter, even the methylcobalamin as well. But I guess our understanding about various phenotypes and personalizing them to these kind of phenotypes, probably there is some role, both of them, looking at various phenotypes of sepsis. Yeah.
Thank you.
Ratan, do you want to say anything on this? Methylene blue and hydroxycobalamin.
Yeah, I have used it in vasoplegic patients who are dilated, and I have also used continuous cardiac output catheters, which tell you about the systemic vascular resistance accurately with the documented severe vasodilatation. When other medications like norepinephrine, vasopressin are not working, in those kind of patients, we have tried using it. But again, it's an individual and very limited use, so can't comment on the outcome as such.
Yeah, anyway, it is not in the guidelines that it is indicated.
Yes.
First line therapeutic module. The available literature, there is significant variability in the reporting, the results. So we have to wait till the further research tells us one way or the other.
So it can be used on case-to-case basis, yes.
Yeah. Dr. Belani has put a note on the current best practices for ICU and OR disinfection. Dr. Belani, are you there? Do you want to read it out?
So I just put I think the discussion displayed most of the things, but I put what is clinically being done. And like you said, it's surface cleaning is most important. And when you have a highly resistant bug, or like when there were COVID times when patients with COVID came to the OR, that's the time you would do the sepsis cleaning of the operating room, where you do the fogging methods. And as far as use of methylene blue and hydroxycobalamin, those are transient and temporary. I don't think they have any sustained benefit, but it does help for temporary use to get the patient to a little bit of a stable state, and then you have to continue with the standard approaches.
Right.
Hydroxycobalamin is also very expensive. I don't know what the cost is in India.
I have no clue. It's basically for vasoplegia, which is resistant to pressors.
It lowers the dose of vasopressor need.
Right. It is not mentioned in the standard guidelines, and actually they have also not recommended teliprecin and angiotensin and this levosimendan. They are all not recommended by the sepsis guideline committee. So that brings us to the end of the session. Any other question burning you want to ask quickly before we wind up and go for our dinners?
I just want to mention one thing. When we are using artificial intelligence, if we can have the mundane or routine work taken care by the AI, something like checking on an X-ray, seeing on a foreign body after cardiac surgery, I think those things become very mundane, and unless you specifically look for, there's a good chance that you might miss. So probably AI, I think, should help with that.
Yes. The AI-enabled ultrasound imaging also is available now. You can do the auto VTI calculations, auto EF, and endocardial detection, border detection, etc. can be done. B-line counting can be done by AI enabled ultrasound machines. So it is clinically relevant, and we have demonstrated that the AI derived parameter is as good as an expert doing it. And that's what we have shown in our series of patients. With that, I would like to conclude this section unless there is anything last comment anybody wants to make. I thoroughly enjoyed this section. Thank you so much for everybody who are present. Starting from Anoop Warrior, Binil, Vikram, Shibu, Vinay, and Ram, Mahantesh, Shabnam, Ratan,
Yes.
Dr. Belani.
Hello. Yes,
Yes.
please. Hello.
Yes, you want to say something? I would like to thank each
Enjoyed
one on
thoroughly.
behalf. Yes, yes, thank you so much. Baljit, are you there?
I'm very much there.
Thank you so much for being with us. Would you like to propose a vote of thanks?
Well, I think you've done a wonderful job, I must say that. And all the experts that you have gathered for such an important topic. It's a very complex kind of thing. And I think to make it simple and make it easily understandable and to give the insights with the recent trends with the management of sepsis in various situations, I think all people have done a great job, and my compliments to all of them. And on behalf of the president of ICA, I must thank each one of you and look forward to having you again on our platform sooner, sooner or later. We'll certainly like to have the benefit of your expertise in the ICUs and other critical areas. Thank you so much, gentlemen. And till we meet again, stay happy, stay healthy. God bless you all, and good night.
Dr. Belani, do you want to say anything?
I think this topic was covered very thoroughly, and I'm really glad that most of the presentations were really up to date and good to learn. I was just wondering about the super bugs, and I did put something up in the discussion which people can review, because those are the things that are very hard to treat, and proper management is important. And I think using a collaborative approach is the key. And as usual, prevention is better than cure.
Yes. Thank you so much, and looking forward to having you once again on the same, webinars and
Thank you,
other
sir.
meetings. Thank you so much. I would like to thank each one of you personally.
Pleasure
Thank you.
always.
It was very well
Thank you,
done.
sir.
Thank you
Yes,
so
please.
much.
Thank you, sir.
Good night, everyone.
Bye-bye.
Thank you, Dr. Baljit. Thank you, Dr. Belani.
Thank you.
Thank you so much, everyone. Good night to all of you.
Good night, madam.
Good
Thank
night.
you, sir.
Thanks, Shashidhar. Thank you. Bye-bye.
Bye-bye.